Thanks everybody so much for being here and for having me. I know I'm one of many presenters that you've seen here today, and I appreciate you sticking around. I was very impressed with the last speaker. Took a lot of notes because I'm always learning. Very excited about that. But you'll see this particular presentation is nothing like that at all. I am not going to share research or anything like that. However, I am going to start us off with some statistics around suicide. The latest year for which we have the data is 2021. So I do want to acknowledge that anytime we talk about suicide, and I realize that this is a suicide prevention conference, it's a heavy topic. And many of us are connected to suicide, whether that is through ourselves, through loved ones. So whatever you do as you sit in this room and taking all of this stuff in, I really do hope that you place a priority in taking good care of yourselves as well, okay? And I'm here afterwards and for the durations. I'm more than happy to talk to anybody who wants to or needs additional support. Okay, so I'm here to talk about the changing landscape of crisis response. There is a lot happening in this field. As noted in my long, brief bio, I've worked in the field for a really long time, and I have never seen this level of momentum, of rapid change in how we take care of mental health crises, individuals suffering through it, their loved ones, and what we can do so much better. And there's so much national drive to make the systems better. So I'm very excited to share some of that with you, but I also really want to clarify that a lot of people have a lot of expectations, potentially not necessarily being able to live up to that. So this is both sides of that. We're going to start, as promised, with some statistics. So in 2021, we had a total of 12.3 million adults and 3.3 million adolescents report serious thoughts of suicide. Okay, these are not just fleeting thoughts. These are not thoughts that many of us can have on a given day where we just wonder what is it all about, but really persistent thoughts, often including planning. Okay, this data comes from the National Health Survey that SAMHSA, our federal government, puts out every year. So it's a very large sample size. So there's some validity we feel to these numbers. However, not that long ago, I took a look at the actual survey and I realized that many of the respondents prefer not to answer to some of these questions. So who knows how truly large these numbers are, right? The same is true for the attempt numbers. So in 2021, our best estimates are that 1.7 million adults and 892,000 adolescents attempted suicide. Again, estimates at best. And then finally, for 2021, the total number of lives lost to suicide were 48,183. Also an estimate. We know that there are many deaths who may or may not have been a suicide, right? There's potential accidents, single car accidents, overdose, and some people are just very good at finding ways to not make it seem like a suicide. So take it for what you will. The reality is a lot of people, a lot of us are impacted by suicide. Way too many. That's a lot of millions of people right here on your screen. And we believe they're underestimates. So that's way too many for us not to talk about suicide, right? Yet it continues to be so stigmatized. It's because of these numbers that we really and truly do need a national emergency number. So the National Lifeline existed prior to this as, and I'm gonna put that up next, as 1-800-273-TALK or 8255. hopefully many of you have seen the logo, this green and white logo behind me. It's been everywhere. It's also been the one that's been used for the Veterans Crisis Line. It's the same thing, okay? So this is really important. 98 is not new. It's just a better way of reaching the national network. As mentioned, it is still the Veterans Crisis Line. So veterans and their family members can call 988 and then press 1. For those who prefer to speak and listen in Spanish, press 2. And since September of last year, this was not initially part of it, but since late September of last year, there is now a third option, and that is for LGBTQ plus youth. Okay, so that gets answered, initially, I should say, was answered by the Travel Project. However, to the national administrators and SAMHSA's surprise, somewhat surprised, this option was very popular. Kind of says a lot about our, at-risk populations, and we really need to pay attention to that. But the option within the first 3 months, I believe, was chosen 16% of the time. 16% is not the number of folks identifying as LGBTQ+. So that definitely tells you that they're at higher risk. So what we've recently, I'm not the federal government, but what the federal government has done, they put out RFPs and added a few more crisis centers in the network who can start answering these types of calls, okay? It's important to note, though, that the Travel Project is peers, so all the folks answering the lines, right, are identified as members of the LGBTQ plus community, though could also be as allies. That's not necessarily true for the other centers, I do not believe. I don't think that that was part of the RFP. This is who we are, just very briefly. We happen to be the oldest one in the nation, the oldest suicide prevention center in the nation. We were an inaugural member of Lifeline when it first came about. We've done chat and text since 2012. We're one of now finally 5 Spanish centers in the network. That is not enough, I can tell you that right now. And that actually just very recently increased. For a very long time, there were only 3 of us, okay? We are California's largest 988 center, and we've also been privileged to be put in a leadership position to lead the implementation and planning 988 efforts for our state, working really closely with the Department of Health Services, California Department of Health Services, and CalOES, which is the Office of Emergency Services. Okay, so I'm here really kind of to talk about what's the reality and what's the promise. So the promise, okay, the promise of 988, really and truly, this will be a transformative moment for crisis care systems in the US. To the level that it needs to be, we're not there yet, but I have every faith that we will get there. There's a lot of work still ahead of us. So the idea behind 988 Crisis Line that is effectively resourced and promoted will be able to allow us to end stigma towards those seeking and accessing mental health care, reduce the use of law enforcement, public health, and other safety resources as first response to it, kind of really meet the growing need for crisis intervention at scale, like have it be appropriate level of care whenever it is needed. And finally, interestingly enough, maybe not something that we thought about, but really reduce healthcare spending, right? Because if we can catch people in a moment of crisis, help them de-escalate, provide them with emotional support, and get them connected to resources, that means they don't necessarily need to end up going to urgent care, to emergency departments, and be connected to ongoing treatment, community-based resources. Right? So that could really actually be more cost-effective as well. The short-term goal of 988 is to really strengthen the network, right? Traditionally, suicide and crisis hotlines have been underfunded, under-resourced, primarily made up of volunteers. Our center, D.D. Hirsch, still has a core volunteer base. So we have about 200 plus volunteers active on the crisis line. So that shows you that this is really what we need to focus on first. Like, let's make sure that we put funds towards these all these centers, there's more than 200 of them in the nation, to really build up capacity. The long-term vision is a much more robust system of crisis care. And what does that look like? It's sort of like a very sturdy three-legged stool, okay? First, we need someone to answer the call 24/7 at any time. That's the focus right now with building out 988, because those are the building blocks. Then we really want to have someone to respond in case an in-person response is needed. Those would be psychiatric mobile response teams, right? The hope is to be at 80% capacity by 2025 for the nation. I think that's too ambitious, but it's okay to have an ambitious goal. And then the third one would be focus is someplace to go. So that means we need to get more crisis stabilization centers, more peer respite centers, and short-term crisis residential homes. Especially for the first two, the CSCs or CSUs, as we sometimes call them, and peer respite centers, there are not enough of them. And I know that for those of you who have lived with mental illness or have family members with mental illness, this is a major, major gap in our system, and we really do need more of them. So that's the long-term vision, but right now, we are in the first phase, which is still building up crisis call centers, okay? Because ultimately, those are the front door to crisis care access. This is really important. 988 is not the mental health equivalent of 911. I wish something like that existed, but it doesn't exist, right? What does that mean? I'm gonna show you the difference. If you wanna think about, like, when do I call 911? When do I call 988? Well, when you have a medical, police, fire, or rescue emergency, you call 911. But when you have an urgent suicide or a mental health crisis, and that can include substance use crisis, then you call 988. The focus is a little bit different, right? 911 is focused on dispatching care, whether that is police, whether it is ambulance, whether it is fire. But 988 is going to focus on, let's talk about this, okay? So the primary focus is to resolve the crisis over the phone or via chat or via text, using the least invasive intervention. That is extremely important. We have to place a priority on confidentiality with 988. It's very different when you call 911. You expect your call to be recorded, and it is. That is not the case with most 988 centers, for example, okay? Over 95% of all contacts, meaning calls, chats, and texts, are stabilized entirely over the phone. Like no other, in that moment of crisis, in-person care is needed, okay? Less than 1%, and I can actually say it's less than 0.0 something, because it is really small, actually needs an emergency intervention. And even with those, we really want it to be a collaborative measure, okay? So involuntary interventions for crisis lines, and this is part of the 988 best practices too, is a last resort only. It's really important to keep that in mind. So what do you expect? Maybe that's another way of looking at it. When you call 911, you basically expect somebody to respond, okay? That's kind of clear, like I have an emergency, I need somebody to help me. When you call 988, it does not matter what the crisis is, you're going to be connected to a crisis counselor. That is the first step. It's not somebody who's going to send somebody to your house. However, 988 centers do need, want, and don't always have access to rescue or intervention, emergency if that's needed. And so those would be connecting you to psychiatric mobile response teams, to co-responder teams. Those are the law enforcement clinician types of teams, or even being able to access ambulance directly or police if it is a public safety issue, okay? There was a lot of misinformation about 988 out there prior to its launch. There was a lot of talk about, oh, 988, they're working hand in hand with the police. And if you call 988 and you say you're suicidal, they're gonna send the cops and you're gonna be hospitalized against your will and you're gonna be drugged against your will. I mean, there were really like some very potent stories out there that may have had an essence of truth because it's based on somebody's personal experience, but carried a lot of misinformation. It was really damaging because it prevented people who are vulnerable, youth, LGBTQ, for example, from reaching out to this very important resource. So I have spent so much time in the last year to just manage the misinformation, to make sure that we're putting the right message out there, right? However, we do work closely with law enforcement, but maybe not in the way you think. So we actually, you see this picture over here, on the right-hand side is our beloved, because he actually passed away a year and a half ago from cancer, and he's been with us for a very long time, the shift supervisor, Ken Denziger. And on the left side, you see Sergeant Chuck Coleman from the LAPD, okay? This is important because this means that there's going to be situations where we really do need an in-person response. The picture of Sergeant Coleman, he's sitting next to a young woman who was sort of the age of his daughter, who had been on an overpass, and the team was called out from MEU, from a mental evaluation unit from LAPD, and they connected, and she came down, and normally then the end result is like, now we're going to transport you, and there's going to be an involuntary hospitalization. But before that happened, he wanted to sit down with her because he was a dad. And he connected with her. And I think that that's actually really important for us to remember too, that there's space for both of these systems. And it's actually really important that we work together. The way we do that on the crisis line, right now we have a pilot, well, it's no longer a pilot because it's been over 2 years, but we have a program in place with LAPD where they send 911 calls to the crisis line if they determine it meets certain eligibility criteria, okay? So it's actually the opposite of what has been put out there, where they're like, maybe this does not necessarily require a response right away. And then we get to resolve those over the phones. We do not know yet what the outcomes of all these other things are because we don't have access to be able to do the dispatch the way we want to. But you can kind of see that if 911 typically has an option of sending either ambulance or police, look at what happens when you call 988. Many more options are possible. These are just some examples. I'm just going to put these up right away. I forgot to set my timer. What? I have a timer. You have 22 minutes. Oh, 22 minutes. Exactly. Very good. Thank you. Thank you. Appreciate that. All right. So I'm going to put these up because I want to give you some ideas of like, okay, you talk about this, but what are some examples of when people make calls? So I'll read them to you. I can't stop thinking about suicide. And I really need to talk to somebody who won't judge me. Or I think my cousin is doing drugs and I'm really worried about her. My friend is thinking about suicide and I want to know how to support them. I feel sad and lonely all the time. I can't seem to shake it off. And I don't know how much longer I can go on like this. Or one of my students is going through a really hard time. He's kind of nervous about calling the crisis line, but he agreed to do it together. Just a variety of reasons why people may reach out. And this last bullet point kind of indicates that it is scary to pick up the phone and talk to a complete stranger about what's going on with you, right? So if you know this about, if you're concerned about a loved one, offer to call together with them. And we get what we call third-party callers all the time. There's several other examples in there about the cousin using drugs or about the friend who's suicidal. Call 988, get support for yourself because that's wearing you down too, right? So what happens then when you call 988? Basically, it's the same all the time. A trained and caring and compassionate crisis counselor is going to answer your call or your chat or your text and basically ask you what's going on. We don't answer the phone by saying, how can I help you? Because that's kind of a loaded question. You can be like, oh, nobody can help me, right? Just tell us your story, here to listen. And then as they listen to the story, they're going to ask you some questions that will help us paint a better picture, get some demographic information. And so these are some examples there. I call you by your first name, which you don't have to give. All of the answers here are voluntary. some demographic questions. We're going to do suicide safety assessment, collaboration on a safety plan. This is not what this presentation is about, but there's a lot to all of this stuff, obviously. Connect you with local resources if you want them, and offer a follow-up call, okay? Not everybody wants that. Not everybody wants to be reminded of that bad moment when they have to call a crisis line, but it's actually the connection. We know follow-up care is super important, and it really can make a huge difference. There's all kinds of research out there that indicates that simply by getting a follow-up postcard, call, email, text message creates a connection, even though it's sort of like a formatted thing. So it's interesting as we develop crisis care systems to really make sure that we place a priority on follow-up care as well. So just a little bit of the first impact since, oh, I forgot her name, earlier presenter, Dr. Walton, thank you. Dr. Walton mentioned a little bit about this as well, like how many contacts we've already had. Just to put it into perspective, if we compare December 2022, so this is just a few months after the launch, versus December 2021, look and see what happened. The calls answered, and this has a lot to do, not just with people reaching out, right? Because that wasn't the issue. The issue was like, let's build the capacity. We were able to answer 48% more calls, 263% more chats, and 1,445 more texts. That's a lot. That's a lot. And that is just the beginning of what 988 can do. For us at the center, we compare 2022 to 2021, we saw an increase of almost 40%. And most significantly, we really needed to grow a lot. So we increased staff almost, you can see both of them almost doubled. Our training classes, I mean, they're around the clock now. And we have more than 200 active volunteers to just manage all of this. Now, we are, as you know, one of the busiest centers in the 988 network nationwide. But that's what's needed, right? A lot of compassionate care and well-trained individuals to manage all of this. Okay, so to talk a little bit about the continuum, I wanted to share this with you. This was last year created by SAMHSA focusing on peer support. So one of the key components of 988 has been an increase of incorporating peers. Peers being people with lived experience or family members, caregivers, even professionals. This is part of who you are. You have experience. We want you to be part of this. I can tell you, having worked in suicide prevention over 25 years, it took a really long time for all these researchers and clinicians in the room to talk about how can we prevent suicide, to actually say, hey, let's get the people who survived suicide attempts in here and tell us what are we doing wrong and what can we do better, right? That took a long time, but now it's much more incorporated. 988 is going to be on the same track. And so the idea is that we need to look at all pieces of it. 3 pieces. We're going to be prevention and early intervention. There's going to be actually crisis care, and then what happens after that, okay? The national guidelines for good crisis care systems. This is from SAMHSA. Forgot to put the thing on there, but it is from SAMHSA. Number 1 is we need to address recovery needs, right? There's oftentimes when you go, let's say you go to the emergency department with chest pains, and you're being seen almost immediately because what's going on? And it's discovered that you have blocked veins. They're not going to send you home and say, you should really call your doctor, right? There is a team is put together. It is all connected. That still does not always happen with behavioral health crisis. So really addressing recovery needs. I already mentioned significant role for peers. We have to have trauma-informed care. You've definitely heard throughout the day how important it is and what significant role trauma can play in the formation of suicidal ideation and behavior. focusing in on zero suicide, yes, it's ambitious, but there's nothing wrong to be ambitious. We can prevent this. Making sure that we have to step away from making it punitive for people to reach out and say, I'm thinking about suicide. But yet that's kind of what happens. You have a student in a school who says, I'm thinking about suicide. Supervisors are called in, many places will call 911, mobile response, parents are called. There's like all kinds of reasons why a student would not say, I'm thinking about suicide. Then that's just one example in one particular kind of setting, right? We need to acknowledge the fact that suicidal thoughts are kind of part of human behavior. Suicide deaths are rare. Those are the ones that we can prevent, but yet we act as if death is imminent the moment somebody says, I'm thinking about suicide. That's the problem. And as I already mentioned, what we're working on is these partnerships. So we have to close a few gaps. And this is what we're doing right now in LA County. These 911, 988, and 211 and DMH access collaborations are super important because it's just too disparate. I already mentioned we're in this pilot program with LAPD. It took a lot of years and persistence and patience for this program to get off the ground, but now it is taken off. Everybody, it seems like in the nation, wants to do something like this. There's an understanding of like, law enforcement wants to focus on public safety crises, not necessarily mental health crisis, unless public safety is a part of that, right? So far with LAPD, over 3,800 calls have been diverted to us, and the success rate is pretty high. Interestingly enough, this is interesting because we didn't anticipate it, but we had a much, much higher percentage of male callers and calls from people of color than we get on our regular 988 line. Way more. We didn't expect that, but what that shows us, and we're actually working with the USC School of Social Work to do some research, evaluation research around this, is that we have a lot more public work to do in terms of like, what is it that we get? Like, why are people, who do we need to educate better? Hey, call 988, not call 911, right? It's very interesting. And then right now with DMH access, I'm happy to report that in the past, we used to have to say, okay, now here's the number to call for you to get mobile response. We are now in the process of at least doing warm transfers for LA County. That's a significant step in the right direction. We need real-time data. We don't have that yet. So when you call me at 988, right, and I talk to you, and we determine maybe really somebody needs to come out, I need to be able to see how many teams are out there. What's the available response time? I mean, what is the estimated response time? And also, where are they going to take you? Where are they even crisis beds? I can't tell you how many times people end up in a hospital. They don't have psych beds available. Now they need to wait for an LPS designated team to show up, transport that person to another hospital. It's not very smooth sailing. So those are the things that we absolutely need to close. The dispatching of mobile response, I already mentioned. We're in the beginning stages of it, but 988, eventually the plan for LA County is for us to do that. There's an office called the Alternative Crisis Response within DMH, and this is through a board motion by a board of supervisors. And this is their aspiration, right? Individuals experiencing mental health crisis in LA County are treated quickly, effectively, and with empathy at the least restrictive level of care. That is what we want, and that is the goal that we focus on and have in mind as we move through this. We do have, like I said, we started this program now, finally, with the warm transfers, but ultimately we need to make sure which teams can we dispatch. So there used to just be PMRT, right? Now, and those still exist, but the Department of Mental Health has also contracted with so far 2 agencies, Sycamores and Vista Del Mar, to put out these FIT teams, MCOTs and mobile crisis outreach teams, and both of the teams are now starting to incorporate peers. So in the past, it was a clinician and a driver, basically, right? And now we're putting peers in the mix. That's actually really important. The goals and needs for all of that I already mentioned. We need the real-time data. We want to move from handovers to actually being able to dispatch them, and not just the county teams, but all the other city teams that are being lifted. Like if I know that I'm dealing with a veteran, I need to be able to call VMedic directly and say, hey guys, there is a person out here and that's the location, here's the situation, and not have to go through all kinds of middlemen, right? Because that doesn't help, that slows things down. Ultimately, we want to be able to have the direct access to, like I said, VMAT, to MET, to MEU, to really directly access those co-responder teams, and even medical transport. Right now, if we determine with a caller an ambulance is needed and it's not public safety, I really want to be able to call LA County Fire or LA Fire or whatever city, but I can't do that. It still has to go through the 911 dispatch. Again, eventually we hope to be able to remove that. This just gives you an idea of like there's lots of work being done in the county, like when it is appropriate to send co-responder, to send just law enforcement, to send peer support, what have you. Just a quick glimpse of that. And then finally, as I already mentioned, we really want to make sure that there is more focus on follow-up care. So right now, what we have at DD Hirsch is we actually, I mean, it's pretty cool. We have a 3-tiered program. This is consistent of emergency or sometimes short-term follow-up. Very purposeful. So I'm going to give you an example of one of the highest risk calls that I can remember. And again, I've been doing this for a long time. We once had a gentleman calling us with a gun in his mouth, okay? Talking about adrenaline shooting up, and the counselor who answered that call, trying to be able to manage that. Did an amazing job, still took him 10 minutes to de-escalate the person to allow him to take the phone out of their mouth, okay? Good, now they can understand each other because that was also part of the problem. Obviously, that is a situation you know right off the bat, this is not going to be resolved entirely over the phones. This person really needs help. It's a high safety risk. But if we're just going to call in law enforcement, we're going to put them at risk as well. And also further escalate the situation, right? One of the reasons we developed this program with LAPD was to also address suicide by cop situations and to lessen the risk of those. So in that particular case, what we were able to do with this gentleman is to de-escalate. We didn't have to do any follow-up. We stayed on the phone with him because he eventually allowed us to call 911 on his behalf. But there are instances where maybe the risk is really acute and the person says, I do not want cops to show up. I don't want anybody to show up. Everybody leave me alone. If somebody comes here, I'm just going to do it. Okay. What do we do in those instances? Well, what we want to do is give them a little bit more time to further de-escalate and put a mini safety plan in place. Maybe it's time for you to drink some water, go to the bathroom, have a bite to eat, take a quick nap, whatever it is. So we can offer follow-up calls 15 minutes later, 30 minutes later, 2 hours later. Those are short-term follow-up calls. We would only offer those to high-risk, high-acute situations. But miraculously, most of the time when we call them back, they have de-escalated. And now they're in a position to say, I'm feeling better and I'm ready for the next follow-up call tomorrow. Or they say, I don't feel safe and I do need help. Thank you for supporting me. And now it becomes a collaborative intervention, right? Standard follow-up care is usually 24 to 72 hours, and then extended follow-up is sort of like mini case management. We also do that. We don't have that with all the hospitals in LA County. We do currently have it with Cedars-Sinai and UCLA Medical Center. We offer follow-up care to patients who have come to the emergency department with a suicide attempt or suicide ideation. So upon release, they're given the option to get telephonic follow-up care from some of our follow-up crisis counseling team. We want to do that eventually for our mobile response clients, for our co-responder team clients, right, when we get to dispatch them, and for our peer-involved follow-up care, which could include homeless outreach and things like that. to really and truly look and see, okay, is it helpful? Were people really linked to the services that we provided them, the resources that we gave them, and do a true community-based and stakeholder evaluation. So finally then, we still have a ways to go, but oh my gosh, we've really come a long way already. We really went from what if we do this thing a little bit differently to actually doing it, to now expanding it. This is specifically true for 988 mobile response dispatch and for the 911, 988 collaborations and diversions. We need to close more gaps, right? We want to go from this patchwork system to more seamless connections. We really want to highlight, and it's very important, the power of law enforcement and mental health collaborations, allowing the community to really speak out, like what is the appropriate response for me and my loved one? What do I really need? And really make sure that we have that available. Really highlight the value of lived experience. I'm very excited about that. We're actually building out training and outreach advocacy within DD Hirsch as well. Ultimately leading to really truly safer communities, safer for everyone, for those who respond, for those who are in crisis, their loved ones, and for the caregivers, right? And that little asterisk that we weren't expecting, actually want to create mental health equity, which clearly we still have a lot of work to do on, and that is all I have. So thank you. In time, okay. Thanks, guys.
Thank you, Sandri. So we have time for about 10 minutes of questions. Oh, got one right here. We'll start with you.
Are you able to see the phone number and location of your callers? And if so, if upon follow-up there's no answer, do you automatically send a first responder for a welfare check?
Wow, that's, yeah, no, I'm not the last one. I hadn't even thought of that. I'm glad you asked that question because there's a really big caveat to 988 services right now in this country, and that is, it is not geo-routed. So when you call 988, you literally get connected to, like, somewhere in the ether, a national platform, okay? Based on your area code, you get sent over to the 988 center closest to you. That would have worked fine 10 years ago when we had to pay very expensive roaming charges, but now everybody keeps their phone numbers. So especially in a county like LA, lots of people live here that don't have area codes that are LA based, right? So that's a real problem. That's an FCC regulatory thing, and it's being worked on. And actually, a bill was introduced by one of our local U.S. representatives, Representative Tony Cardenas, who introduced an yay. You're okay, good. Your district, good. Who introduced this legislation that this really needs to change, right? The pushback, as you can probably imagine, is coming exactly from people with lived experience. They're like, I don't want anybody to know where I'm at. The reality is that we don't necessarily want to know that either. As you saw, less than 1% of the calls really needs an intervention. So we do not know where the person is calling from. We do have caller ID, and that's the extent of it. So, yeah.
Question. Back here. Question?
Yes.
Okay.
Follow-up.
Okay, hold on.
So just to follow up with that in mind, if somebody calls with a different area code, like I have a Chicago area code, right? But if I were to dial 988 from here, I'm routed to somewhere in Chicago.
Yeah.
And so what happens then if there is an in-person intervention needed in that case? How do they make it happen?
Yeah, that's a really good question, and that obviously gets complicated, right? So what they would have to do is connect, find resources online, just like all of us would, like Google it, what's available in LA County. There isn't a nationwide national database or resource that all these centers can connect to. Maybe eventually that be the case, but that's also why 211 collaborations are so important. So for those of you not familiar with 211, they are our favorite resource that we give out, is they are the experts, and they know how many shelter beds are available. They know all the local resources, and we don't know that. And we don't have the resources to maintain them, right? So that's one of the primary reasons why that really does need to change. Yeah.
I think we have some online questions. First question, can I find volunteer information on the website? Can we take the training and also volunteer?
Yes. Yes, please. So for us, for DD Hirsch, it's just going to the ddhirsch.org website and find your way over to volunteer services or for the Suicide Prevention Center. And like I said, we have trainings around the clock now these days, so a lot of them, yeah.
Next question, what is your take on the amount of discussions that should be on suicide awareness and prevention in school districts?
Well, that's kind of a broad question. What I can say is that, so we do a lot of training and outreach to schools and all kinds of different settings, but particularly with schools, we know for youth, and so I'm primarily talking about high school students, but also middle school students. There's always a big and realistic concern about contagion, right? So we know that if schools do not have good prevention and postvention plans in place, we can actually see, well, and I don't like this word, but sort of copycat behavior. That's a real thing. This is also why, for those of you who are familiar with 13 Reasons Why, that series, why we had so many problems with it, because it wasn't really giving a lot of good adult role models in there, and to really step away from that. So I think it is very important that we provide accurate and information, but also support. Like we've had some recent potential clusters in LA County in a number of schools, and we've been working with them for support and prevention trainings.
I have a live question here, and then we'll go back.
Yeah, the 98 option for LGBTQ, the slide said it was like 25 and under. How tight is that age range? Because I have a child and she's turning 25, so it's gonna mean she's gonna be 26 soon.
That's a good question. I doubt anybody calling it, and if you say I'm 20, I am 26. Sorry, you pressed the wrong button. No. I know this for sure because back in the days when the Travel Project first started, we were actually the crisis line who answered those calls. We did that for the first 5 years of the Travel Project, and it was a really wide variety, of calls that we got. So absolutely not a problem. Yes, it's just that they're focusing in on, the youth population for obvious reasons. Yeah.
Maria, back to you for online. Can MCOT place a child on hold? Can we request MCOT if PMRT is unavailable?
That is also a very good question, and there isn't really one over the other. Ultimately, PMRT and MCOT is not going to be a big difference. The focus, when they roll out the MCOT teams, there had to be designated peer. The PMRT is also changing to that same setting. So I believe in both instances still they are LPS designated, so they should be able to place people on hold if need be and transport them to urgent care or hospital settings.
Hi, Marie. I imagine calls can be very intensive at times. Wondering how responders to those calls are able to stay calm. Also, wondering what practices are practiced for self-care and to prevent burnout.
Yeah, that's a never answer. Thank you for asking that question because it is challenging. One of we put a lot of measures into place providing support to our volunteers and staff on an ongoing basis. And if anybody here has tickets you want to donate and things like that, those are the kinds of things that we do for our teams to provide them with some little extras. But yes, self-care is a really important part of what we do. The National Vibrant, who's a contractor for the National Lifeline, actually puts out a series of trainings and webinars and workshops being made available to all the 98 centers on self-care, deep breathing and meditation, all these kinds of things. Our system is, and this is now true, I believe, for almost every center out there. Crisis counselor is never alone. There's always a shift supervisor, and they're available for debriefs, and they are in direct contact with each other throughout via chat as well. Yeah, it's a very important part of this work.
All right, we have time for one more question from the audience. Do we have one more? Oh, Adrian.
I was just curious, there's a system in LA County that we use for finding hospital beds called ReadyNet. Is that something that might be that real-time solution?
Yeah, thank you for mentioning it, yeah, and so that's something that is being built out further because not everybody is on there and it's not always exact, but we need to know, that in real time, so LA County DMH right now is building out technology for that to be much better, and they are also working with the state, Cal OES, as new technology for 98 centers interoperability with 911 and 211 and what have you, all the pieces of the crisis system of care that we can communicate better with each other. So yeah, thank you.
All right, thank you, Sandri. Everyone stand up and give her some applause. I'm gonna have everyone wake up. Yeah, thank you.